Hello, beautiful people, and welcome to this week's episode of the Montpelier Happy Hour, where we talk about how everything in Montpelier shakes out for the rest of us. I'm speaking today with Emily Kornheiser, one of three reps from the town of Brattleboro. We're also joined today by Rep Lori Houghton, who is joining us from Essex Junction. And if you don't know me, I am your host, Olga Peters. And we're going to be talking about the Healthcare Committee. Is that right, Lori?
That is right. That's where I served for the past 3 terms and hope to again.
Well, very glad that you can join us, and it's lovely to meet you.
Thank you.
For those who don't know Lori, yes, she is a House Rep out of Essex Junction. She is a ranking member on the House Committee on Healthcare, as well as I believe you serve on the task force on affordable, accessible healthcare as well.
Yes.
So
that task force is done, but yes, I did serve on.
Okay, that was my next question. You know, I went online and check things on the legislative website, which if folks aren't familiar with it, if you go to vermont.gov, you can get to the legislative website from there. And it's very useful, but I'm also very aware that we are changing from one biennium to another. And some of the information might be in flux. I'm curious, Lori, big picture, looking ahead to the next biennium, what are some of the big things likely to fall on the committee table?
Yeah, great question. So there's a lot going on. There's a lot of follow-up from things we did last session. So I'll start there and then some new initiatives. So we passed legislation Act 167, which has a lot of different components to it. But one is healthcare reform and doing a new all-payer model. There is looking at the blueprint, which is around primary care. There's looking at our regulatory system. So there's a lot of reports, because we're really good at reports in the legislature. There's a lot of reports due back in January that we'll be following up on. There's also oversight. So there was a lot of workforce development money that was passed and supposedly put out the door by now, which it hasn't been. So we'll be doing some oversight on that. Mental health is a really big issue. Obviously, everyone's impacted, especially after the pandemic. And we're looking to Department of Mental Health on some follow-up items, such as peer certification and peer support, mobile crisis and urgent care centers, as well as ensuring that the new 988 prevention line helpline is available for everyone. And then new initiatives, we're going to look at continuation of our reproductive health legislation and how we protect providers and insurance companies and people now that Article 22 has passed. And then we're also going to look at suicide in terms of population health and how we can bring our numbers down and protect more Vermonters. So those are just some of the issues we have.
No small issues.
No small issues.
Is the committee, how much of the committee's work is still sort of cleaning up from COVID? Because when I went on the website, I just gave a quick look to some of the bills that the committee looked at last session. And, you know, there's a lot around telehealth and COVID issues. Many of those coming forward?
There'll be some continuation. So telehealth, definitely. I personally would hope that we look at audio only again. So our telehealth, we passed it before the pandemic, about 2 days before, interestingly enough. And in that bill, we had put a 5-year sunset, thinking it would take that long for people to come up to speed on using telehealth. Obviously, the pandemic changed all that. And so we've refined it over the last couple sessions. And now we need, I think, to go back and look at audio only to ensure that people who, have broadband issues or, transportation issues and still need that connection, right, to a doctor, but can't do it on video. So that's an issue that will come up. And then honestly, health equity, which we knew, but really didn't know the effects until the pandemic. And so I envision us to continue looking at that as well.
Thank you.
But as for, COVID itself, I think we're hopefully, knock on wood, done with that.
Fingers crossed.
Yeah.
I'd love to just circle back quickly to health equity. That is a big term. It covers a lot. Could you just, for the sake of listeners, pull that apart a little bit?
Sure. So, and I apologize, my time frames are all off, but we passed major legislation, I think 2 sessions ago, and put into place a health equity office for healthcare. And so that legislation did a couple things. First, it created an advisory group or commission, I don't remember what we called it, to start looking at what we need to look at, but then also to help set the parameters of what the health equity office would be. And so we'll need to come back to that. We also realize that everything we do needs to be in several different languages, right? And not only languages, but one of the bills we took up last year was around hearing aids. And as a committee, we realized we needed to change how we operated to ensure that community could be represented at the table when we were making decisions about hearing aids. So we had to have a translator come in. And it was a really interesting process. And you realized how privileged, as 3 people are here who have our hearing, go about our day. But so those are the types of things we need to keep looking at.
Thank you. Emily, what are you thinking about around healthcare these days?
Well, it's interesting to think about sort of transitioning from like the immediate impact of the pandemic to the aftermath of the pandemic. And so, you mentioned mental health, and how there was this horrifying article in Vermont Digger about the Bennington Elementary School. I don't know if you either of you
just
saw
read that today.
About really handling some very intense and very like usual behavioral challenges that I think our elementary schools all over the state are facing, but they're using police to deal with that in Bennington. And I imagine likely because they don't have the resources that they need to handle it otherwise. That's the story I'm going to tell.
Right.
But it just really was such as if there was not enough evidence of the really extreme mental health challenges that we're facing. That we were facing before the pandemic that have really been exacerbated by it. And so I'm curious about your thought, to just go deeper on what we think is needed there. Because here in Brattleboro, we are a locus of a lot of conversations around mental health for a number of reasons. We host the retreat, but it's also culturally we're a place that has probably more therapists per capita than anywhere else in the country. I mean, I'm just making that up, but I think it's probably true.
But we wouldn't be surprised if it's true.
Wouldn't be surprised,
Right.
And we have, some really, extreme impacts from family substance use that impacts our kids, and just all the issues we think about down here. And what comes up over and over is sort of emergency rooms.
Right.
But we know that it's really upstream and downstream that we experience those challenges. And so I'm curious, how healthcare is so complicated. Mm-hmm. And so how do you do all of it? Or how do you pick out the one thing that might make a difference in the context of that huge upstream downstream universe?
Yeah. It's so hard. And we often tell people that in the healthcare committee, we work around the edges, right? So it's so complicated, and we're so reliant on the federal government with funding. And also with the funding comes certain rules. And so here's a really good example about impacting the schools. So we have a program called Success Beyond 6, which has been in existence for decades.
Forever, yeah.
And forever. And it helps provide the mental health resources in schools. But a student, to receive those services, a student has to have a diagnosis. So some of the issues that are happening in schools, there's no diagnosis yet for that child. And so therefore the school doesn't get the funding that they would need to have a person to help that child. And so, that's a really big issue. So we work around the edges is how we determine where we're going to take up. So in regards to, kids, Department of Mental Health is going to be coming out, or has come out with a couple RFPs. We're getting a lot of funding from the federal government. So through some of the various ARPA and different programs that have come up under this president, we're going to be getting millions and millions and millions of dollars to set up some new programs. Part of the issue is workforce. So we can set up all the programs we want, but are we going to be able to get the people to work in them? There's a mobile crisis unit in Rutland that we set up, I think, either 2 years ago or last biennium, I forget which one, and they are not fully active yet because they don't have the workforce. So I don't know if I answered your question, Emily, but I mean, we kind of try and go to what's going to impact the most people in the state of Vermont that we can actually do something about.
And I feel like
it's kind of a sad response. I'm sorry.
No. I know it is. It is. It's, when I first came into the legislature, I'm like, we're going to change the world and we're going to change our healthcare system. And I'm sure that's what many of the new people who are coming in who put down healthcare as a committee selection want to do. But unfortunately, we can't, sadly, but we do the best we can.
It feels like down here, a lot of what we're struggling with is less about needing new programs and more about getting the programs we have to work as they were intended.
Yeah.
And one thing that we've been talking about on the happy hour a lot is how hard it is as a legislator, as a citizen legislature, and given our limited staff and limited time, to really be doing the deep accountability work with existing contracts and programs. And I'm curious, as you envision the year, are you thinking about different ways to do that? I haven't heard very many folks lead with we're going to look at past programs and see how they're working. And so I got really excited when you said that, even though it probably didn't feel all that sexy to say. But I'm how do you envision that working and having it be meaningful? Because I really don't feel like our structures are set up for us to do that well right now.
It's really hard, but I will say in healthcare, most of what we pass has to be kept being looked at. There's not much that we pass that we shouldn't be going back to, because it's a continuum, right? So, mobile crisis. So we set that up in Rutland. We have to go back and look at it in order to then say, well, how are we going to, make it better? How is it working? Is it not working? It's not working right now, all the time because of staffing. But then we're going to try to create mobile crisis programs all over the state. We have to learn from that. So, what we do in healthcare, we rely on our legislative staff, the few that we have, really a lot, as I'm sure you probably do, Emily, in your committee, to say, okay, these are all the things we passed, in previous bienniums. They keep a running tally. And then we go through each year and determine what we need to go back to. We can't get to everything. And so I'm sure there are things that aren't working that we can't get back to, but we try really hard. But something, Olga, that's even more depressing is, so under the Medicaid, I'm sorry, my dog's barking. Under the Medicaid program we have, waiver, the 1115 waiver, we have investments that we can make. So money can go into certain investments as long as we don't go over a cap or something. So every biennium we say, okay, let's talk about these investments. And literally the department gives us a list with a name and the amount, and there's probably 110 investments, and we don't have the time or the capacity or the staff to get into them, so we don't know if it's working or not. Now, I did talk to the department, and they're going to start looking at things like that. They have someone who's actually really intrigued by that too, and wants to be why, what's working, what isn't. So it takes everyone, and unfortunately everyone's understaffed and busy, but We try.
Can you explain the Medicaid waiver to us a little
That'd
bit?
be good.
Sure.
'Cause I think there's, myself even, there's single payer, there's the Medicaid waiver, and there's all payer.
Right.
There's three different things. So can you?
Yep.
Thanks.
Sure. Yeah. And actually, this is one of the, and I'm going to start with something else, but it'll lead into it. So in healthcare, we think when people who don't know, who come into the committee or, others say, okay, well, we need to do these things in healthcare. We assume, as I did when I came in, that it would impact anyone getting healthcare in the state of Vermont, but it doesn't. So we have Medicare, which is for 65 and older. That is completely done by the federal government. We have absolutely no say. So when we have a constituent that calls and has a problem with their Medicare, we have to send them to the office of the healthcare advocate because there's nothing we can do. There's no legislation we can put in. Medicaid is for lower income people. It is guided by the federal government. So they set most of the overlaying policy and rules. They fund it and we fund it. So we can make decisions, and a lot of what we do does impact people on Medicaid within certain parameters that the federal government has set up. Then we have self-insured programs.
Wait, before we
Yeah.
jump to self-insured programs, is every kid on Dr. Dinosaur considered part of the Medicaid population?
Yes. So Dr. Dinosaur is considered part of the Medicaid population. We passed recently legislation that does a Dr. Dinosaur-like, because we, interestingly, if you're someone who's here with a undocumented, let's say you had a child in Guatemala and you come here and you have a child in the US, so that child that was born in the US is a US citizen, they would have access to Dr. Dinosaur, but the child who was born in Guatemala would not. So we passed legislation to ensure that those children have coverage through Dr. Dinosaur. So that's Dr. Dinosaur, and that's part of Medicaid. And then also under Medicaid is, there's so many different programs under Medicaid, but we can do a lot under Medicaid through what's called a waiver with the federal government. So we just got a new waiver that lasts for 5 years. And some of the things that will allow us to do is provide housing supports. So people who are in housing, we can now use Medicaid to provide supports for those people, whether it's, social service, like, help with just social services, help with substance abuse, help with all sorts of things. So we've never been able to use Medicaid dollars for that. And so that's a program we'll be setting up.
Wow.
Yeah, that's going to be really exciting.
And so
you have a question.
It's huge. That's like huge and thrilling.
Yeah.
So I think, I know that lots of people, myself included, like, number one issue I heard about from constituents when I was first campaigning was healthcare. Showed up like, why can't we do this? And one of the big why can't we do this is like, why can't we spend money upstream to prevent spending downstream, right? And like social indicators of health, and like some people call them social indicators of health, and some people don't have that technical term, but that's usually what people are talking about. So the idea that we could use our Medicaid for that is exciting. How much of that is like the legislature can be defining what that waiver looks like, and how much of that is like just within sort of strict administrative control?
So the negotiations for the waiver was strictly administration, but now that we have the waiver signed for 5 more years, and we, as the legislative body, we can help provide policy input as to what those housing structures supports should look like.
Okay.
Are there other things we can do with it? So that's where we fall into play. But the actual negotiations is done between the administration and the feds.
Yeah. And when you say administration, are you talking about the governor's administration or the Department of Health?
Both. So it's usually Agency of Human Services actually would do the negotiations. Yep. So Agency of Human Services, which is the broad overlay, and then the various departments underneath it, such as Department of Health, DMH, DEVA. DEVA, Department of Vermont Health Access, is actually the department that manages the Medicaid program for Vermont. and they sit under the Agency of Human Services.
And it's
Thank
separate
you.
from the Department of Health, totally separate from the Department of Health.
Yes,
And
totally.
Personnel wise, my understanding is that the new secretary of the Agency of Human Services came from DEVA, right?
Yes, yes.
And so
She did come from DEVA.
She has like a lot of expert. I think she's the person who last negotiated the waiver, and so she has a lot.
She was, yes. And I will say, at the end of the last session, there were a lot of concerns about the waiver negotiations and the fact that we would probably be losing a lot of money. And we instead have a very good waiver. So the team at AHS did, and Jenny Samuelson, the secretary, did an amazing job. Yeah.
I've heard we have the best waiver in the country, actually, from a few people.
Yeah, I think we do.
Nice. Yeah. We have a few minutes, Lori, before we need to go to break. So if you wouldn't mind, we started this conversation with you defining the different types of...
Yeah. And how much control we have.
Yeah,
so,
if I can go back to that, it'd be great. So, and it'll be easy. So, or quick. So I talked about Medicare. I talked about Medicaid, which we can, and about 22% of our population, I believe, gets Medicaid insurance through Medicaid. Then we have self-insured funds. And so these are businesses that provide insurance. You know, there might be cost sharing, and normally is cost sharing, but that they're, so like UVMMC is a self-funded fund. So anything that we do does not necessarily impact those who are providing self-funded insurance. They could choose, let's say when we passed legislation that said everyone needs to be able to have access to hearing aids once every 3 years. They could choose to offer that to their people, but they don't need to. So that's self-funded. So we really don't have anything on that. And then there's people who fall under like large corporations that offer their employees health insurance. So that they're called ERISA plans, and I have no idea what it stands for, but they're from the federal government. We can't touch those. And then we have what you buy on the exchange, Vermont Health Connect. So it's about 35 to 40,000 individuals who buy on Vermont Health Connect. And then there's about 35 to 40,000 individuals through small businesses who buy on Vermont Health Connect. Everything we do can impact them. So we have Vermont Health Connect, about 75,000 people. We have Vermont Medicaid, about 22% of the population.
How many? I never know how many people are in Vermont. So how many you gave?
I think so. Yeah. You know, I was worried you're going to ask me to do math, which I'm not really good at. So there's, 600,000. I want to say total, we impact about 200,000 Vermonters when we make changes in the healthcare committee.
And that's like a third of Vermonters, you're saying?
About a third of Vermonters.
Okay.
Interesting.
Yes.
Nice math together. Appreciate that.
Yeah. So I've started saying to people, when you talk to Vermonters and they're talking about healthcare and they have a question or they're concerned about costs, I say to them, please find out where they're getting their health insurance, because that will help direct the conversation of what we can and can't do.
Thank you. We have to hear from some of our underwriters here on the Montpelier Happy Hour on WVEW 107.7 LP Brattleboro, your community radio station. So hang on, we will be right back. Welcome back, beautiful people, to the second half of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. You can also find us on BCTV. We thank them for putting us out on the airwaves, as well as you can subscribe to our podcasts, and you can also find us at our webpage, which is the montpelierhappyhour.captivate.fm. If you are just joining us, I'm your host, Olga Peters, and I'm speaking with regular contributor Emily Kornheiser, who's one of 3 reps from the town of Brattleboro, as well as Representative Lori Houghton, who is zooming in from Essex Junction, and she is a ranking member of the House Committee on Healthcare. So you can guess what we're talking about too, if you're just joining us. Hey, Emily, what do we need to remind listeners of?
The views and opinions expressed here on the Montpelier Happy Hour are those of the host and the guests, respectively, and not the station, nor platform, nor friends, family, or employers.
Thank you very much.
Mm-hmm.
Lori, in the first half of the show, thank you so much for breaking down the kind of different tents that healthcare insurance falls under, or people can walk into in Vermont. I would love if we could talk a little bit about the Green Mountain Care Board, which, and I would love if you would start actually with what is its role, and why do we have it in Vermont?
Well, and if I could just add one more framing to that question, I think one of the interesting pieces about sort of how we can support, control, change the buckets that we can, it's like, is that something the legislature can do, or is that something that the Green Mountain Care Board can do, or is that something the administration can do? And those are three separate sort of power nexuses. So
yeah,
completely.
And I think a lot of people, and it's still hard for me sometimes, it's hard to know which bucket it falls under, right? And there's, I think, a lot of misperception that Green Mountain Care Board can do more than they can. So the Green Mountain Care Board, and I was not in politics or anywhere close to it when they were formed, but my understanding is that they were formed to bring us to single payer under the Shumlin administration. Prior to that, all regulation for the healthcare industry was done under BISHCA and Department of Financial Regulation. So it moved to the Green Mountain Care Board, which is has 5 board members. All are nominated by a nominating committee. So you apply to the nominating committee. The committee does their work. They send recommendations to the governor, and then the governor makes the selection. So the Green Mountain Care Board has really one main role, and that is a regulatory body for our healthcare system. So they approve insurance rates. So Blue Cross Blue Shield and BP must go before them every year with their plans. And then hospital budgeting. That's really what they do. And so they don't pay providers. They don't set the rates that people pay providers, but they approve the budgets for hospitals and insurance companies. And I don't apologize, I don't have the numbers, but they have, they have maintained or lowered the cost of healthcare in Vermont by controlling those budgets. Now, some would say they've done it too much and the budgets don't have the revenue in the budget to actually be successful. So it is a sticky point. Then some of the other things they do is they do work with, or one of the main things they're doing right now is they're working with the Agency of Human Services on a new all-payer model and on some healthcare reform initiatives. But their primary role is regulatory.
Okay, before we talk about all-payer,
yep.
Why don't they just say no to rate increases? Like, I think, across the board, I hear from folks like, oh my God, how can I have felt it myself. Like, oh my God, how can insurance rates go up so much faster than like anything else, and certainly faster than my paycheck is going up? So why can't they just say like, hell no, health insurance company, you can't increase your rates that much?
So they could, but then our quality of our services would really fall. So, healthcare is expensive, right? So we need a new MRI machine to be able to do preventative care or to provide care through any type of cancer treatment. That costs a lot of money. Labor costs have gone up. We need a lot of nurses our demographics are changing. We're getting older. That usually means more care. Hospitals provide a lot of community support. They do a lot of stuff that we don't really see. So right now, their hospitals are one of the main places for people struggling with mental health, unfortunately. So, there's a cost to help that. And hospitals are having to change their EDs a little bit to be able to accommodate people who are suffering with a mental health condition. So there's just it's normal cost of doing business, right? They're not immune to all the costs that other businesses have.
And so our health insurance providers in Vermont this is really exciting. I've never actually been able to ask all of these questions. So thanks. It's such a straightforward way.
I wouldn't call it exciting, but it's interesting.
It's exciting for me. So our health insurance providers in Vermont are nonprofit organizations, and they really love.
So are all the hospitals.
That. Yes, and they all and particularly the health insurance companies really like to brag about that on VPR in their little. They're not called commercials. Yes. What do they call it? Underwriting.
They're underwriting.
Underwriter.
Yeah. Underwriting.
And so, and yet, it's really hard for it not to feel like there's just must be this massive profit taking somewhere, because where is all the money going? And so how does it work that Blue Cross is a nonprofit here, but not a nonprofit, is part of a national thing that's not a nonprofit, I think? And what does it mean that they're a nonprofit?
So, being a nonprofit just means that they're not paying they're not paying shareholders. So there's no stock that needs to increase. There's no shareholder saying we need more dividends rather than, putting it back into the care of their customers. So, being a nonprofit basically means the money is going right back in. But I agree. So, some would say, and some have said, well, hey, there wasn't a whole lot of care being done during the first year of the pandemic. No one was going to any hospital or doctor's offices. Gee, shouldn't we have gotten some money back like we did with auto insurance, right? I don't know about you. I think I got a $10 check for mine.
That was the best check ever.
It was very fun. But, insurance companies have to have reserves, right? They knew that once doctors' offices opened up again, and they were right, that all these people were going to be coming back probably with conditions that were even worse because they hadn't been there. So healthcare is not a normal free market entity, right? And we actually had testimony on this a couple of years ago by a Montpelier professor. It doesn't follow the rules of the free market. And that's really hard for a lot of people to understand.
So what rules does it follow?
Well, so you go to buy a car, right? You're going to go and research different car companies, different auto dealers. You're going to check out prices. When you have chest pain, are you going to call around to see what hospital is cheaper to go to? You don't, right? So, it's just how we as individuals handle our healthcare. We want to go where we want to go. And we don't normally think about cost until after the fact. So that's one way. We're not shopping around for healthcare.
And it's interesting because there's all of this pressure around price transparency.
Yeah.
And I appreciate that because I just generally, I'm transparency. Yes, always, please.
Right.
And I don't know how price transparency would change any of my decisions whatsoever with regards to my healthcare.
So we passed price transparency several years ago. Have you ever looked it up? Right?
No. And I guess I like to think it's useful in the in the same way government transparency is useful, in that it doesn't change people's decision making. It creates the opportunity for accountability when things are sort of outrageously off the rails.
Right. Yeah. Right. So I looked it up. So when I went to get a colonoscopy, I looked up. It was preventative, right? So my insurance covered it, but I went online and looked up at all the hospitals around me that I could go to. And there was a wide range, right, of pricing. But because it was covered as preventative medicine and I can go 10 minutes from my house, I went to the most expensive one. And I'm on the healthcare committee, so I understand the effect that that has. Because although it's covered under preventative and the big pool of things, we're all paying for my colonoscopy at the end of the day. So it is, thank you. It is an interesting industry. Yeah. And we all manage it very differently. Yeah.
Mm-hmm. So bringing it back to the care board, you gave us a nice rundown of kind of what they do and prices.
And they do, and I'm sorry, I will say, let me interrupt real quick. They do a whole lot more, like behind the scenes. Like, sorry. So we, as a legislative body, actually look to them for a lot of our help with reporting. They have a lot of data available to them, and they have a really good team of people who really understand healthcare. And so there's a lot of things, like they helped us with the price transparency legislation. They have, they're working on a healthcare sustainability, hospital sustainability study right now. So there's other things they do, right? But it's mostly regulatory, not some policy, but not as much policy. So sorry, I didn't mean to interrupt you, Olga, but I wanted to get
that. No problem. And as I understand it, there are some changes happening with the board.
Yeah.
Would love a rundown
I actually just met. Yeah, I actually just met with the chair this morning. So like I said, they serve 6-year terms, and it just so happened that the chair of the committee, Kevin Mullen, who was fantastic, he retired early. So that role was up, and then a year and a half early. And then another care board member was at her 6 years and decided not to put in for nomination again. So the nominating committee, of which actually I'm a part of, and then the governor selected Owen Foster, who is really an interesting guy. So he's the chair, and he used to do health care fraud litigation in the state of Vermont. It was he's has some really interesting stories. Yeah. And so he's the chair, and then we have I think, and I might get this wrong, David, I believe, is an emergency care doctor or a physician at a hospital. And so we finally have a physician
in a long time, right?
First time that I know of. Yes. There might have, no, I mean, there were 2 previously, but it's been a long time.
Yeah.
So he's great. And then Robin Lunge, who was a member, has also been reappointed for a year. So we have 2 new members, and then 3 members that came back. We're still on it. Yeah.
And are we anticipating with this change of leadership, any different issues to come before the board, or the board will be focusing on things differently?
Well, I don't really track what the board does all that closely, but I was really thrilled to see just some like very basic accountability questions from the care board to the one care board.
Yes.
Which really paralleled some questions I had asked 2 years ago and been like, I don't understand why you are not answering me, but like, I'm a new legislator, who am I? And so I like felt incredibly vindicated by this recent care board meeting that I'm sure you know much more about than I do, Lori.
Yeah, I would say because Owen Foster as the chair is new, and although has a healthcare litigation background, has never been in politics, has never, been part of the conversation, that he will start asking some questions that may not have been asked and wanting more accountability, simply in an effort to learn, right? But also to make sure he's helping Vermonters, which is his main goal as chair of the Green Mountain Care Board. So yes, I was happy to see that too, Emily. And I think they will start looking more at quality than maybe they have in the past. And as the healthcare committee, we have to start looking at quality again too. Through the pandemic, a lot kind of got lost because we were focused on the pandemic. So we need to go back to, are we providing the right care at the right time in the right place? And a big piece of that is quality. So, but can we talk about the care board? I mean, one care really fast.
Please do. I
Because
think,
I
especially
think
in
that
this
is
neck of the woods, I think a lot of people don't necessarily run into the One Care board, do they?
probably not. And I also think a lot of people don't know what they really do.
Well, because they don't
So,
really tell you when you ask them.
right. That could be a reason, right? Yeah, that would be helpful. So an accountable care organization, which is what One Care is, was part of the Affordable Care Act, which passed under President Obama. And the main role of the One Care in Vermont is a means to do payment reform, because they're the entity that takes the money, right? So the money that's already in the healthcare system, so the money that Medicaid has, goes through One Care, and they then, because it's a capitated model or fixed payment, they can then send the money out to the hospitals, who then give it to the providers, right? They can do the same thing with Medicare, and they can do the same thing with any commercial insurance. There's a lot of rules in healthcare about privacy, and so you kind of, I mean, Medicaid Diva could probably do this role, but then we would have to fund them and have people to do this role. So a lot of people think that One Care kind of controls the pot of money. They don't. They just take the money and pass it out to where it's supposed to go.
And the
So
idea
when
is
people,
it's supposed to go to pay for like preventative and like person-centered care, community and person-centered care, rather than like intervention-based reimbursement. Is that the idea?
so what kind of the idea is, we are changing the way we pay providers, right? We want everyone to be paid on value-based payments rather than fee for service. So not everyone is doing it yet, but for those providers that are doing it, and all of Medicaid providers are doing it, so I'll use them as an example. So Medicaid knows the people that they will provide insurance to, and they do a risk assessment, and they work with One Care, and One Care says, okay, and they come to an agreement on what the pot of money is going to be and what hospitals get what pot of money. And then between Medicare and One Care, they are running some programs, and One Care does some case management. But really, they're just taking I'm going to make up numbers, $100 million of Medicaid and giving, 10 million to 10 hospitals in monthly payments. And then if Medicaid goes over that in providing care, then that gets settled out at the end of the year. If they go under, that gets settled out at the end of the year. Sorry for the dog again.
It's okay.
And so I guess my question
So does that make any sense?
Emily?
I'm going to put you on
It
mute.
does. I guess and we really don't mind dogs or cats or fish or anything.
Don't.
Show. It's fine. How is that supposed to make people's lives better?
Because, well, it should eventually make healthcare cost less. Because if you have a doctor who needs to do so many services to make a living, they could potentially provide care that they don't, or testing that they don't need to have, versus having a value-based payment system is, you have all sorts of providers that can now work together to help Lori Houghton achieve whatever she needs to achieve, because we already know what we're getting paid, rather than, so my primary care says I need this thing, this specialist. Really, I could work with my primary care, who could just have a conversation with a specialist, but because the specialist is on fixed fee for service, they actually want to see me. So they can charge for that appointment. So one, there could be wait times, there's unnecessary costs when I could just be working with my primary care provider. So that's an example
Okay.
of how it could help us.
Thanks.
Some would say we don't know yet if it's going to help us, but some people would say it has helped us.
When will we know?
Yeah, and how will we know?
Yeah, so we're a really healthy state. Like, we're one of the healthiest
I
states in
know.
this country. Yeah.
That's pretty cool.
And we
And so
have
many
one of
people
the
aren't
low,
healthy.
I know, right?
right. And we are the lowest cost state for Medicare because we are so healthy. So sometimes it's hard. Like, I would say, well, how healthy are we? That's a good indicator. Well, we're already really healthy. We have things we're targeted to, like diabetes and suicide. So we need to see those rates coming down. So what are we focused on through this new model? And are those metrics improving, decreasing, whatever they're supposed to be doing? And that's where I say we have to get back to the quality, and we have to start looking at those metrics again, because that has been lost the last couple of years.
It's there's this whole construct in energy efficiency work, which is basically like there's a lot that can be done to sort of lower our climate footprints, increase energy efficiency, like for a certain, like with an initial intervention, which is like you get a state to swap out their light bulbs and get new dishwashers and whatever. And like it's very easy to spend money to have like very clear results on that. And then a state gets to sort of, or a community gets to a certain level of energy efficiency, and the interventions become like much more expensive, much more complex, much more system oriented problems. And like Vermont is there on the energy efficiency thing, like Efficiency Vermont, which is another one of those sort of like state coordinated, but not controlled by the legislature. How did this get created? Right. Who are they accountable to? Kind of bodies that were like not sure what metrics make them successful. So I think it's sort of a useful parallel. And they've gotten us to this place where like we're doing well and we're not doing as well as we need to. And it becomes really hard to show. It's sort of interesting to think about how do you, I go to conferences, I don't know about you, I show up being like very aware of all the suffering in my community and the state. And I get to the conference and everyone's like, oh, you all are fine. And I'm like, well, we're fine by American standards, but like, look how like the rest of the world is doing. So like, in fact, we're not fine.
We're not fine. Right.
Yeah.
And we have Vermonters who suffer. Like it's not fine. It's great that we're better than other states, but it's not great because there's still people out there who are suffering. Yeah. And I would say, to your analogy, Emily, I would say we're not there yet, like energy efficiency is, because we can do more on the preventative side. Like we need to invest in more primary care doctors. We need to pay primary care doctors more, because we know that is how you control the downstream spend, right? You do it here. So I know that was part of this Act 167 that we passed, and we'll be getting some information back this year on what we need to do to help primary care providers. I don't know about you. Oh, see, there's another animal.
I picked him up before he decided to claw his way up.
Oh, there you go. Anyway, I lost my train of thought, but primary care is a big concern.
Now, with something like OneCare, will one of the markers ever be out-of-pocket expenses for folks going down?
Yes, we're not there yet. And it's interesting, when I became a legislator 6 years ago and we just had started on this, I think the all-payer model had just been signed like the year before. It was signed like 3 days before we were signed in or something. We were sworn in or something like that, right? Yeah. And I remember being at a legislative breakfast with everyone, and my question was, okay, this is great, but when are we going to see copays and premiums and everything go down? And I think every professional who knew what they were talking about looked at me like I had 10 heads. And they're like, well, that's not what this is about just yet. This is about changing the way we deliver healthcare. And once everyone is in the same boat and we're all steering the same way, then we should see reduction to the individual pocketbook. Unfortunately, it's a really big boat that is moving really slow, unfortunately.
Well, one reason I asked the question is perhaps being a little cheeky, but early in the show, we talked about health equity and health access, and people's ability to afford care is, a piece of that equation. And so it made me curious.
Yeah. I will say this. So I have a public awareness announcement, I guess. So we're in open enrollment right now with Vermont Health Connect. So, and the federal government is giving us a lot of subsidy money. So it used to be people would say, oh, well, I'm not going to try to go on Vermont Health Connect. There's no way I'll get help. Well, people making up to, I think it's families making up to $265,000 can get help with their premium cost. So I encourage people, if you are uninsured or if you're buying direct from Blue Cross Blue Shield or MVP or Cigna on an individual or family plan, that you go to vermonthealthconnect.gov and see if you can get help. You can probably get the same plan you have through Blue Cross Blue Shield, but to get the subsidies, you have to buy it on Vermont Health Connect. And Blue Cross Blue Shield is fine with it. So they will encourage you to do it too. So I really, really encourage people to check it out. And it ends December 15th if you want care starting January 1st, insurance January 1st. And then it's opened until, I think, the end of December if you wanted to start February 1st.
And so that could make it possible for people to buy a higher premium, lower copay, lower deductible plan, maybe, because the premium.
Yes, exactly.
Okay.
Right. Yeah. I mean, I will say, because I just did this on Vermont Health Connect, and the deductibles are really high, but the premiums are doable. And when you look at premium and say, okay, I'm paying premiums in order to get the preventative care I get, I would really encourage people to take a look.
Thanks.
Yeah.
Thank you, Lori. Unfortunately, we are out of time, so I just want to check in with Emily and Lori before we sign off to just say, is there anything else you wanted to let listeners know before, or any kind of threads you wanted to tie off before we?
Lori, I want to know one thing that makes you excited about the new legislative session. It doesn't have to be related to healthcare unless you want it to be.
I think all the new people. Like, I really think there are some people coming in with some amazing ideas with unbelievable backgrounds. And, it brings excitement into the building that will hopefully carry through to the session.
Wonderful.
How about you? Can I ask real quick, Emily, how about you?
I think I'm really excited about the scale of change we're about to experience in the culture and the possibility in the legislature.
Yeah. Great.
Wonderful. Well, Lori, Houghton, thank you for joining us today.
Thank you.
If people want to learn more about you or the healthcare committee, where can they go?
They can go to my website, lorihoughton.com, or they can email me at houghton.lori@gmail.com.
Thank you. Emily, how about you?
Folks can go to emilykornheiser.org and you'll find links to all my email addresses and phone numbers and social medias and such. And with the legislative session starting in January, regular constituent coffee hours, Zoom meetings, library events, all of those are starting again. And so please find one and come talk to me.
Wonderful. And as always, you can find the Montpelier Happy Hour on WVEW 107.7 LP Brattleboro every Friday at 2 p.m., wherever you find your podcasts, as well as BCTV and our Captivate page. Have a great weekend, everyone.